Hi, I'm Dr. Edwin Fernando, Professor of Nephrology from the Government Stanley Medical College, Chennai. And I've been asked to speak to you about urinary tract infection. Urinary tract infection is something very common in the general population. And there is a difference between men and women in this particular aspect. So I'll begin by saying men and women aren't created equal when it comes to getting UTIs. So over the next 15 minutes, I would talk to you about urinary tract infection in men. UTI is uncommon in young adult men. In young men, the prevalence of bacteria is quite low. Males less than 50 years, again, it's very low incidence of UTI. But with increasing age, you'll find there is an increase in the structural and functional abnormalities in the urinary tract that cause obstruction and turbulence to the urine flow. So, in patients who are 85 years or older, the prevalence of UTI increases much more. So, when are men and women equals, then, as far as UTI is concerned? The incidence of UTI in men approaches that of women only in males who are over 60 years old. Why this disparity? The transitional epithelium, it conducts urine from the kidneys to an elastic bladder. This can store large volumes at low pressures. The male urethra is separated from the rectum by several centimeters of keratinized squamous epithelium. The long urethra, it's about 18 to 21 centimeters long, provides an additional barrier between the bladder and the perineum. And the prostatic fluid contains some antibacterial substances. And all UTIs in males to be considered as complicated. So this is a picture showing the anatomy of the male urinary tract. You can see the long urethra, about 18 to 21 centimeters. And it is very unusual for a healthy male to develop UTI unless it's a childhood UTI or a UTI above the age of 60. So why UTI is common in young male infants? The male infants, it accounts for about 75% of UTIs. The risk factors being congenital anomalies of the urinary tract. Circumcision, UTI is tenfold greater in uncircumscribed individuals versus the circumscribed infants. So the anomalies being the peliectasis, hydronephrosis, vesicoureteric reflux, posterior urethral valve, the PUG obstruction, congenital strictures. So a child develops UTI, a male child develops UTI. It's mandatory that we look into it seriously because this could be a congenital anomaly that is presenting as a UTI and it requires a very serious workup and follow-up. What are the risk factors for UTI? Young people, homosexual behavior, especially anal intercourse with a female infected or colonized with a uropathogen, lack of circumcision, acquired strictures, gonococcal strictures, immunodeficiency states like diabetes, HIV, and steroid use. In elderly, obstruction from any cause, common being the prostate, stones, traumatic strictures, urogenital malignancy are major risk factors. Any instrumentation of the urinary tract is definitely a risk factor. Catheterization itself, make sure that you really want to catheterize somebody. Don't catheterize somebody for our convenience, but whether the patient really requires it. Major urological surgeries where a catheterization or instrumentation of the urinary tract is done are major risk factors for UTI. See, what is the pathophysiology? It's similar to that of the females. The usual route of inoculation in males is with gram-negative bacilli from the gut. May occur due to infection from other portions of the urinary tract, typically the prostate. Entry of microorganisms into the prostate gland occurs via the urethra by intraprostatic reflux of urine through the prostatic ducts. The prostate could be a very silent area of infection, and when a male with recurrent UTI, where you're not able to find out any other cause, it's imperative that you look into the prostate. Of course, when somebody has hematogenous route of infection and through the lymphatics from the rectum. So what to look for? A thorough physical examination with particular attention to the kidneys, the bladder, the prostate, and external genitalia. Look at costovertebral angle tenderness, flank tenderness, palpate the suprapubic area, look for tenderness or mass. Look at the external genitalia. Look at the penis for ulcers or lesions, urethral meatus. palpation for urethral strictures, testis and epididymis for tenderness and swelling, rectal examination for prostatic tenderness. These are the things that you would normally do when you look at have a patient with UTI. The classification of UTI is again the upper UTI, pyelonephritis involving the kidney, the lower UTI consisting of urethritis, cystitis, epididymitis, and prostatitis. Cystitis is a rare event in males without concomitant infections in other portions of the genitourinary tract, associated with anatomical abnormality, defect in the bladder emptying mechanism or urethral catheterization, high voiding pressure and poor bladder compliance diminish the natural uroepithelial resistance to infection. Elevated post-void residues allow bacteria to multiply to critical levels. It's very important when you do an ultrasound, ask the radiologist to look at the post-void residue. The symptoms being frequency, urgency, nocturia, dysuria, and suprapubic pain that are clinically diagnostic. Pyelonephritis is infection of the renal parenchyma. Infection is usually retrograde, ascending from the bladder or hematogenous. Urethral orifice becomes edematous, loses its one-way valve function during infection. Retrograde flow of bacteria into the upper urinary tract and into the renal parenchyma, resulting in clinical symptoms, and may occur hematogeneously. The prostatitis symptoms are pain in the peritoneum, lower abdomen, testicles or penis, or ejaculation, sometimes blood in the semen. Acute and chronic prostatitis can happen. May arise via dysfunctional voiding, intraprostatic reflux, chronic exposure to microorganisms. And most common cause of relapsing UTI in men is E. coli with a main causative organism. Acute prostatitis, fever, chills, malaise, dysuria, pelvic or perineal pain, and cloudy urine. Obstructive symptoms, swelling of the acutely inflamed prostate, and these range from dribbling of urine and hesitancy to anuria. Rectal examination, the prostate is warm, swollen, soft, boggy, and extremely tender. Probable pathogens being E. coli, Klebsiella, Pseudomonas, Enterococcus, Staph aureus, and coagulase negative Staphylococcus. Chronic prostatitis can have symptoms of at least 3 months. Many are asymptomatic. Symptoms include dysuria, frequency, urgency, and peritoneal discomfort. Rectal examination may be unremarkable or may reveal severe anal sphincter spasm, and prostate may be mildly or extremely tender. The prostate is one silent area where infections can be occult, and one needs to think of it in patients with chronic UTIs. And this is a 4-glass test that is generally described when you want to express the prostatic secretions. You first ask the patient to void the urine, and then the bladder midstream culture is taken. Then you do a PR and do a prostatic massage, and then collect the first 10 ml urine after prostatic massage. In this way, the prostatic fluid could be taken for examination and cultures. Epididymitis and cystitis, most common cause of acute scrotum in an adult male population. Common pathogens being chlamydia and Neisseria. Retrograde ascent of infected urine from the prostatic urethra into the vas deferens, and finally into the epididymis. The epididymis is generally tender and indurated, and in hours 2 days, the inflammation can progress to the adjacent testis, scrotal pain, and swelling. So, how do you make a diagnosis? Urine analysis is very important. Threshold for establishing a true UTI. If you find more than 5 or more WBCs per high power field, it's imperative that you do a urine examination because the most often missed test. Urine culture is essential for the management of suspected UTI. Specimens always to be obtained before the initiation of antimicrobial culture. The common mistake that's done is you always start the antibiotic and then look at a culture, then it is likely to be negative. Cultures to be done only when symptoms and signs are potentially attributable to the UTI. The specimen collection is very important here. I feel that most of us don't instruct our patients how to culture the urine, and most of the laboratory personnel also do not instruct. So the patient just goes in, gives a sample of urine and come in. This can actually have false positive, especially the anterior urethral or organisms in the foreskin could actually be misinterpreted as an organism growing in the urine. So first ask the patient to clean around the urethral meatus. Retract the prepuce to clean the urethral meatus and reduce the risk of contamination. And you start passing urine into the commode. You have your urine culture bottle in your left hand, and then after passing about 15 to 30 ml of urine, you insert the bottle. It's a wide mouth container, and then collect urine. So this method of collecting urine is called a midstream urine, and I think this is mandatory. I would recommend that this picture be put up in any laboratory so that patients are instructed very clearly how to collect the urine. Bacteriuria without pyuria could be contamination or colonization. Pyuria is very non-specific, it's not diagnostic of symptomatic UTI or a need for an antimicrobial treatment. Absence of pyuria has a negative predictive value of 95% to or more to rule out UTI. Sterile pyuria could be because of multiple causes: non-gonococcal urethritis, chronic prostatitis, renal tuberculosis, perinephric abscess, fungal infections, interstitial nephritis, genitourinary malignancy. So somebody has persistent sterile pyuria, advise you to look at this list of causes. Significant bacteriuria is when there is an isolation of single organism with a count of at least 10 power 3 CFUs, that is colony forming units per ml from a voided specimen. More than 2 organisms with counts of more than 10.5, 10 to the power of 5 CFUs is consistent with symptomatic infection. Isolation of the same organism from the blood and urine could be taken as a support of diagnosis of urosepsis, and identification of the same strain in repeat infections suggests bacterial persistence within the urinary tract. Febrile UTI in males, immediate assessment of upper urinary tract or rule out obstruction of the anomalies is mandatory. A CT with contrast is the most sensitive imaging test. Make sure you check the creatinine before looking at the contrast. Ultrasound is of course more accessible and can be done at the bedside now. I rule out a prostatic hypertrophy with obstruction, urethral strictures, bladder or renal stones, or a bladder cancer. A post-void residue of 100 ml or more is considered abnormal. So make sure your radiologist asks the patient to void urine and then assesses the post-void residue in all patients with suspected UTIs. A catheter, a Foley's catheter, is again one of the common devices that's used in a hospital. Sometimes you use a catheter for short-term catheterization for 2 to 4 days when a patient is acutely ill. 15% develop bacteriuria due to a single organism. The catheter-associated bacteriuria usually resolves after the catheter is removed. 1/3 of patients may have symptoms of bacteremia as most serious complication. Long-term catheters, you can have polymicrobial infections and all patients develop bacteriuria. No reliable colony count cuts off definition of bacteriuria. Low-level colonization can progress to high level in 3 days in patients who are catheterized for long. And catheter-associated UTI is growth of more than 10 power 3 CFUs per ml. Antimicrobial treatment of asymptomatic bacteria is not indicated as it promotes resistance to antimicrobial agents. Cystitis and pyelonephritis, similar to that of women, that we shall see shortly. So, when somebody's got cystitis, these are the usual group of antibiotics that you use: trimethoprim, sulfamethoxazole, trimethoprim, then nitrofurantoin, or we use one of the fluoroquinolones for a short duration of time, 3 to 5 days. If you have a pyelonephritis, then you will have to go for parenteral antibiotics, and you need to treat this for at least a period of 2 weeks. Ceftriaxone, cefepime, these are regimes that you can start off awaiting a culture report. Make sure that you send the cultures in before you start the antibiotic. Acute bacterial prostatitis is again empirically treated with broad spectrum parenteral antibiotics, extended spectral penicillins, fluoroquinolones, or ceftriaxone with or without aminoglycoside. Remember, when you're using an aminoglycoside, make sure you check a creatinine prior to starting, and also a creatinine maybe 3 to 5 days after the therapy. Once improved, you can start off with a trimethoprim or fluoroquinolone. And in an acute bacterial prostatitis, it is mandatory to treat for a minimum of 4 weeks. A Foley's catheter is significant urinary obstruction, and difficulty with urinating is frequently present, and alpha blocker may be considered in such patients. Chronic bacterial prostatitis can be usually treated with fluoroquinolones or trimethoprim sulfamethoxazole for 30 days. Fluoroquinolones are usually the first line therapy. Levofloxacin, ciprofloxacin are equally effective. So this is a flow chart that shows you if there are UTI symptoms. Look at the vital signs, abdominal examination, rectal examination, urine analysis, culture, post-void residual urine by ultrasound, antimicrobial therapy if clinically indicated, and abdominal imaging CT or ultrasound, referral to a urologist, urological management if there are stones or some results are abnormal, and if you need to do a cystoscopy or a correction of functional or structural abnormalities. If there is recurrent UTI and the same strain, then you'll have to look into the upper urinary tract or the lower urinary tract by looking at what could be the etiology. If it is a different strain, is for watchful waiting, and if there is no recurrence, kindly keep looking at the urine. The prevalence of bacteriuria and incidence of UTI is substantially higher among older women than I mentioned earlier. They have underlying urological abnormalities. Effective treatment determines whether the site of infection is kidney, bladder, or prostate. Depending on where the infection, you have to alter the management, the duration of therapy. Effective management of asymptomatic episodes requires selection of antimicrobial therapy on the basis of urine culture. Chronic bacterial prostatitis requires prolonged antimicrobial therapy, at least 30 days. Having spoken about UTI in males, let's go to UTI in females, which is a much more common problem. And this year, the World Kidney Day talks about kidneys and women's health. That's the focus of this year's theme of World Kidney Day. Incidentally, 8th March 2018 was World Kidney Day as well as International Women's Day, and that's why the theme was made this way. You can see this beautiful emblem logo showing a lady hugging a kidney or a kidney hugging the lady. So UTI in women is a much more common problem, and this is what we would see in and day out. It's a common and painful human illness. 25% of bacterial infections in women are UTI. 150 million people per year are affected by this. And if you take women, 50 to 80% of women would have reported UTI at some point in their lives. And approximately 10 to 15% of antibiotics that are prescribed in the world are for UTI. UTI occurs more commonly in females than in males. Exceptions are, of course, infants and the elderly. Neonatal period, the male infants are more commonly having congenital urinary abnormalities that I mentioned. After 50 years, the obstruction from the prostate is a major problem in men. The risk factors in the females, one is environmental. You know the anatomical disposition of the female urethra, the vagina, as well as the anal canal are in very close proximity. Environmental, vaginal ecology, sexual intercourse, new sexual partners, spermicides, postmenopausal women, these are the risk factors. Then you have anatomical or functional abnormalities like the male urethra is about 18 to 21 centimeters long, while the female urethra is just 4 to 5 centimeters long. Pregnancy is another factor that could alter the functions as well as anatomy. And then maternal UTI, biological, genetic, first episode less than 15 years, non-secretors of the ABH antigen and mutations in the gene for the TLRs and IL-8 could be genetic factors. But the most important thing is the very short distance of small segment of urethra. Very easily an infection from the vagina or from the anal canal can get into the urethra in a female. So these are the various ways how a female UTI works out. Contamination of the urethra, then colonization of the urethra, migration to the bladder, then it ascends up, there is neutrophilic infiltration, bacterial multiplication inside the immune system, biofilm formation, and then epithelial damage that is done by the toxins and other proteases ascends to the kidney, and then there is colonization of the kidney, damage to the kidney, and then bacteremia. So this is a very serious issue. The infection, colonization or elimination depends on three things: the organism, the host, and the environment, the type of organisms, the virulence factors, the genetic background of the individual, behavioral factors, underlying disease like diabetes, environment, the vaginal ecology, anatomy and urinary retention, or medical devices like the catheter. The uropathogens, these are the common causes of UTI, most common being the E. coli. You find that uncomplicated UTI is 70 to 95%, as well as in complicated UTI, about 21 to 54%. Kindly remember that gram-positive organisms can also cause UTI. So when you are sending your cultures, make sure your laboratory also checks out for gram-positive organisms, as nearly about 20% of organisms, UTIs, are from gram-positive organisms. The method of specimen collection again is very, very important in the female. Again, I suggest that these pictures be put up in the laboratory or in your consultation room as to how a female should collect urine for culture. So the labia majora has to be separated, and then with saline it has to be cleaned from above downwards, 1, 2 and 3 swipes with 3 different swabs. And then with the labia majora separated with the left hand, the patient should start passing urine with the wide mouth container in her right hand. And as she is passing urine, after about 10 or 15 ml are passed, then insert the tube in between and collect the urine. So again, this is called the midstream collection. And if the patient is not instructed and they would straight away go to the toilet and just collect the first sample of urine and hand it over, you are going to get organisms from either the vagina or from the anal canal, or infections in the labia majora, etc. And this could cause you fastidious organisms or organisms to grow, and then unnecessary antibiotic therapy, etc. So it's mandatory that you instruct patients, put up these pictures at a point where the patients collect urine so that they know how to do it properly. The classification of UTI again based on the anatomical level. The upper UTIs I mentioned to you: pyelonephritis, pyelitis, urethritis. Lower UTIs are cystitis and urethritis. The clinical syndromes being a UTI is asymptomatic, uncomplicated UTI, complicated UTI. In uncomplicated you have cystitis and pyelonephritis, and then complicated also you can have cystitis and pyelonephritis. Asymptomatic bacteriuria is absence of symptoms referable to the urinary tract. Same uropathogen in 2 separate consecutive clean voided urinary specimens, both with 10 power 5 or more CFUs per ml. Found in about 5% of young adult women, generally benign, high risk in pregnancy, urological surgeries and transplant recipients. Healthy adult non-pregnant women can have acute uncomplicated cystitis. Dysuria, frequency, urgency, suprapubic pain are the usual presenting features. Acute uncomplicated cystitis could be secondary to sexual intercourse. Pyuria is almost always present, and more than 10 power 3 CFUs in the midstream urine is significant. The treatment would be again very simple: trimethoprim, sulfamethoxazole, trimethoprim, fluoroquinolones for a short duration of about 3 to 5 days. These are the usual drugs that are generally given. Recurrent cystitis, 2 or more episodes in 6 months or 3 or more in a year. 20 to 30% of UTI women would have 1 episode of UTI, which will have recurrent episodes. Likelihood of recurrence disease decreases with increasing time since the last infection. Relapse is early recurrence within 2 weeks, evaluated for a sequestrated focus. Reinfection is recurrence after 2 weeks. Antimicrobial prophylaxis before any prophylaxis regime. Eradication of previous UTI should be confirmed. Counseling and behavioral modification should be attempted. Continuous post-coital antiprophylaxis with one of these agents is indicated. Acute uncomplicated pyelonephritis is fever, chills, flank pain, nausea, vomiting, costovertebral tenderness, and urine analysis almost always showing pyuria. Urine culture of more than 10 power 4 CFUs in 95% of patients. Do an ultrasound, rule out urinary tract obstruction, and if necessary, do a CECT. The infected kidney is often enlarged, decrease the pacification of the affected parenchyma, and before doing a contrast, make sure the creatinine is normal. Uncomplicated UTI that increases the risk for serious complications or treatment failure. Complicating factors could be major problems, obstruction of structural factors, urolithiasis, urethral or urethral strictures, bladder diverticula, renal cysts, foreign bodies, indwelling catheter, urethral stents, nephrostomy tubes, functional abnormalities like neurogenic bladder, vesicoureteric reflux, and others like a renal failure, renal transplant, immunosuppression, or a multi-drug resistant uropathogens. Parenteral regimens include ceftriaxone, piperacillin, tazobactam, imipenem, meropenem. You could start off with one of these pending the culture reports. Oral regimens with levofloxacin could also be tried. UTI in postmenopausal women is a special problem. Diabetes mellitus, sexual activity, atrophic vaginitis, UTI before menopause. These are risk factors. Incontinence, cystocele secondary to prolapse of the vagina, post-void residual urine. These are very common. Rule out urinary tract obstructions such as urethral stenosis. And cystoscopy and urethral dilatation may relieve the obstructive symptoms, especially when patients have a high post-void residual urine, or in the case of a dry vagina, one can use an estrogen cream for the prevention of UTI. UTI could be special problems during pregnancy. Asymptomatic bacteria is common during pregnancy, and patients should be screened for bacteria during the second trimester. About 40% of women with symptomatic bacteria can develop pyelonephritis during pregnancy, which could be very serious. Treatment of asymptomatic bacteria in pregnant women is important as it decreases the risk of pyelonephritis by 70%. And asymptomatic bacteria in pregnancy is associated with preterm death and perinatal death, and one needs to take this very seriously. These drugs are quite safe during pregnancy: nitrofurantoin, amoxicillin, cephalexin, and monthly screening with cultures throughout pregnancy is mandatory. I wish to thank all of you, and I hope this session was useful in the management of urinary tract infections.